Today I'm talking about total knee replacement. We had a talk from Pandeli a couple of weeks ago about osteoarthritis, and he talked a lot about the non-operative treatments. And today I'm going to talk about total knee replacement, and I've sort of taken it from the viewpoint of the actual sort of technical considerations, mainly intraoperatively, and how to achieve a good result with knee replacement. What I'm going to talk about today, I'm briefly going to talk about the history of total knee replacement. Briefly on what we need to do to work up our patients pre-operatively. And I'm going to go quite a bit into the technical goals and techniques of total knee replacement, as well as prosthetic design, and a quick mention about failure and complications. I guess it's always important to know where we've come from as far as any of the techniques we use and what hasn't worked in the past and why, so we don't repeat the mistakes in the future. First sort of knee replacements documented in the 1880s and 1890s with Gluck in Germany, who used an ivory hinged knee replacement, mainly in the setting of patients with tuberculosis. And he didn't have a particular success with that, but it was probably due to the fact that he was operating on very difficult patients as well. In the 1940s, interpositional arthroplasties and tibial surface replacements were used. And then the 50s and 60s, hinged prostheses were used, but these were often associated with failure. Big advancements in technology came about in the 1960s with polymethyl methacrylate or bone cement, as well as polyethylene, and these are key components that we still use to this day. The modern knee replacement was really born in the 1970s with the evolution of condylar total knee replacements. And these initial designs from the 1970s have basically just been slightly modified and improved upon in recent times. This is a schematic diagram of Gluck's initial hinged prosthesis, which, as you can see, had a couple of components that linked together to form the joint. And he used this not only in knees, but in elbows and wrists as well. This is an example of an interpositional arthroplasty from the 1940s, which was put in between the existing tibia and femur. And some examples of some early hinged prostheses from the 1940s. And this is the evolution of condylar prostheses, initially with ones with separate prosthetic parts for the condyles. And then what we're more familiar with knee replacements looking like today, the condylar type total knee replacement. This is an example from the early 1970s from Japan. And this one actually had cutouts at the front and back of the tibial insert to allow for both the ACL and PCL to be preserved. And then Insull's condylar knee replacement, again from the 1970s, started to sacrifice the ACL. And this very busy slide here looks at the evolution of condylar knee replacements, and that, as you can see, a lot of them are related. And one of the confusing things with orthopedics is often a small change is made to a knee replacement and it's completely renamed. So it's hard to know exactly where they've come from. And this particular prosthesis is interesting in that this is the Melbourne prosthesis, which is a hinged prosthesis that was designed and developed in Melbourne in the 1970s, and some post-operative images of that. Unfortunately, it didn't do particularly well, and it had a very high failure rate. So we talked a couple of weeks ago about the workup of patients with osteoarthritis, and then Pandeli gave us a very good talk about history examination and maximising the non-operative management. And when we've failed with non-operative management and the patient is still not happy or is continuing to decline in their function, we can have the choice for a total knee replacement. And we need to understand it is elective surgery. We need to make sure our patients are up to that. And we need to make sure our patients have a good understanding of what they're going to go through and their expectations with that. And we need to adequately image these patients pre-operatively and plan for what we're going to do. And it's been shown that consistent results really do rely upon having good preoperative planning. The recommended preoperative radiographs are pretty standard lot there with AP and lateral views. Now, it is recommended that patients have a standing AP full leg alignment views to help with the planning. It's not something that I guess we see everyone doing, but it is something that is probably recommended. And in the modern day and age of preoperative planning, using digital templating markers to help scale our x-rays for digital templating programs is becoming more and more common. So our goals for total knee replacement is what we're trying to achieve for our patients. So primarily we're trying to get pain relief for our patients, but having an improved mobility can also lead to an improved quality of life. And then we have technical goals ourselves and what we're going to aim to do intraoperatively to try and achieve these patient-oriented goals. And the key technical things are looking at restoring proper mechanical alignment of the limb, preserving or restoring the joint line or joint height, and balancing the ligaments and soft tissues, as well as maintaining or restoring a normal Q angle to allow proper patellofemoral tracking. So if we talk about each of those things, first of all, looking at restoring mechanical alignment. Now, this slide here shows the various axes of the lower limb, both anatomical and mechanical axes of the femur and the tibia, as well as the overall mechanical axis of the lower limb, initially in what's a normal patient and that with a valgus or a varus knee. Now, the reason we want to maintain a normal or a neutral mechanical alignment is so that the forces of the knee, or the forces pass directly through the middle of the knee, and this will equally load up the medial and lateral sides of the knee replacement and will prevent any sort of excessive wear or early failure due to that. So if we think about the axes of the femur, we have an anatomical axis which is defined as a line that bisects the medullary canal. Intraoperatively, this anatomical axis is important if we're using an intramedullary guide to make our femoral cuts, as where the anatomical axis exits in the notch is basically where our intramedullary guide is going to go. And the femur also has a mechanical axis, which is a line from the center of the femoral head to the point where the anatomical axis intersects the notch. And having a neutral axis, as I mentioned before, shares the load between the condyles of the femur. And intraoperatively, the difference between the anatomical and mechanical axis determines our valgus cut angle of the distal femur. And usually this is quoted between 5 and 7 degrees, but it can alter depending on the height of the patient. Taller patients will have a lower angle between their anatomical and mechanical axis and a lower valgus angle. And our cut angle was perpendicular to the mechanical axis. Looking at the tibia, again, the anatomical axis is defined as a line that bisects the medullary canal, and the mechanical axis is a line from the center of the proximal tibia to the center of the ankle. Now, in a normal as such tibia, those two lines are coincident, but if there's any deformity in the shaft, they are different. And this we need to consider when we're using jigs to cut the tibia, making the choice of an intra or extramedullary guide. And this diagram shows those things. So with the femur, we talked about the anatomical axis coming down the shaft and the mechanical axis coming from the center of the hip to the center of the, or where the anatomical axis exits in the notch. And our distal femoral cut is perpendicular to that mechanical axis, but it's valgus compared to the anatomical axis. In a normal tibia, we have both a mechanical and anatomical axis that are the same, and a tibial cut which is perpendicular to that mechanical axis. And obviously we could use an intramedullary guide for our tibia if we had a dead perfectly straight tibia like this. But if we had a tibia that had a deformity in it, you can see that using an intramedullary guide is going to be difficult, and that's why most people would go with an extramedullary guide to remove that. So again, looking at this diagram about mechanical alignment, so when we've talked about all those different axes, and our aim is to try and get a neutral alignment so that we're making our cuts perpendicular to both the mechanical axis of both the femur and the tibia, which will make our knee replacement parallel with the floor when the patient's standing. So the second technical consideration is talking about restoring the joint line or joint height. And this is because in an unconstrained knee replacement, the ligaments play a vital role in the kinematics of the knee. And it's shown that knee function is optimized when that joint height is preserved. And the key really is that we need to be able to remove enough bone in making our cuts to allow the prosthetic replacement. But we don't want to remove too much on either side and drastically change where the joint line is. So we want to maintain what's a normal joint line for that patient. And the problems with altering things, if we elevate the joint line, we can have instability in mid-flexion, problems with patellofemoral tracking, or an equivalent of patellar because the patella is now sitting lower in relation to the femur. And lowering the joint line can lead to a lack of full extension or strength with extension, as well as some flexion instability. This diagram shows what we're talking about. So we're aiming to have the joint line preserved as to where it should be in this patient. If we raise the joint line, then you can see effectively, because the femoral component is higher up, then they're getting a degree of patella with that. So the things we need to consider, we need to know our patient, so we need to have an idea in our preoperative planning, looking at their x-rays and having an understanding of where their joint line should be, and whether or not there's likely to be any defects that may need to either be grafted or augmented. We also need to know our prosthesis, because our prosthesis is aiming to replace the bone and cartilage. We need to know the thickness of our prosthesis and how much we're cutting off the femur and tibia to be able to restore that. And modern instrumentation obviously makes this easier for us in that it can provide very precise bone cuts, but there is a degree of user error with it, so we need to be careful with placement of our cutting guides. Next technical consideration is the ligament or soft tissue balancing. Now, in the degenerative knee, the soft tissue can become quite scarred or contracted, or alternatively stretched. And we need to achieve some balance with this when we put in our prosthesis to allow optimum or even loading and optimum function. And we need to consider this in both the sagittal and coronal planes. When we're talking about coronal plane balancing, we're talking about varus and valgus alignment of the knee. And the basic principles to doing this balancing is we need to release on the concave side of the deformity and fill up on the convex side, I should say. So in a varus knee, which is most of the patients we see, the concave side is medially, so they will need a medial release. And a valgus knee, that concave side is laterally, and they will need a lateral release. And when there's a number of structures that can be released to achieve this, and that needs to be done in a sequential manner, but we need to be careful of over-release and destabilizing the knee. Sorry, that should be extension, yes. Sagittal plane balancing is we want to obtain equal flexion and extension gaps so that the prosthesis is balanced and stable throughout the arc of motion. And to do this, we need to consider what articulates an extension and inflection. Obviously, the tibial plateau will articulate throughout the range of motion, but in the femur, the articulation goes from the distal femur to the posterior condyles. So if there's a gap problem that is symmetrical, either if it's loose in both flexion and extension or tight in both, then we need to adjust the tibia. And if there's an asymmetrical problem in flexion and extension, we need to address the femur. And again, that goes down to the fact that the tibial cut affects both flexion and extension, whereas the distal femoral cut affects the extension gap, and the posterior femur affects the flexion gap. And again, you can think from this diagram, if we take more tibia off, it's going to affect both the flexion gap and the extension gap, but the extension gap can be governed alone by a distal femoral cut, and the flexion gap by the posterior. The fourth consideration is maintaining the Q angle to allow for proper patellofemoral tracking. We've had talks already this year about abnormal patellofemoral tracking in the knee in general, and how it can create a lot of problems for people, and that's something we need to consider as well with knee replacement. And obviously, if we're increasing the Q angle, we're increasing lateral subluxation forces, and this can lead to patellar tilt and patellar maltracking, and this can be symptomatic with our patients and make them very unhappy. Now, the patellofemoral tracking can be altered with various different parts of knee replacement, so it needs to be considered a lot of the time throughout with what we're doing. A reminder, the Q angle is the angle between the anterior superior iliac spine and the midpoint of the patella, and the midpoint of the patella and the tibial tubercle. So here's a table looking at those various technical considerations. So in placement of our femoral and tibial components, as well as looking at our overall mechanical axis and our patella component, as well as the joint line, there are considerations we need to have. And simple things, for example, the femoral component position, whether or not it's medial or lateral. You can imagine if we put it a lot more medial, it's going to increase the Q angle, because it's going to force the patella to be more medial in relation to the tibial tubercle. So moving on from the technical considerations of carrying out the operation to actually looking at the prosthetic design. So there's three broad types of knee replacement. There's unconstrained knee replacements, which are the most common ones we see for primary knee replacement. And then there's also constrained non-hinged knee replacements, as well as constrained hinged. The constrained hinged tend to be used for revision procedures. Constrained non-hinged can be used for either primary or revision, depending on the stability of the knee. And unconstrained, the two basic types we have are those that preserve the posterior cruciate and those that sacrifice it. This is an example of a cruciate retaining unconstrained total knee replacement. And then a constrained non-hinged knee replacement, and the constraint is in the varus valgus, or the coronal plane, by having a tall tibial post that prevents the prosthesis having excess varus or valgus. And then we can move on to a prosthesis where the actual tibial and femoral components are linked by a hinge. One thing in considering the design of prosthesis is understanding the concept of femoral rollback. Now, with our normal knee, as we flex our knee, the point where the contact forces are going through the knee progressively moves more posteriorly with increased flexion. And this reduces bony impingement and allows more flexion. In a normal knee, this is controlled by both the ACL and PCL, but it's shown that rollback does occur with a PCL only, although it's not as smooth as with an ACL and a PCL. And this is an example in a native knee of femoral rollback, and you can see the contact point as flexion increases moves more posteriorly. So in a prosthetic design, early implants allowed femoral rollback to obtain optimal flexion, and by using a flatter tibial insert, it allowed the femur to roll back on that as it flexed. But this means that there's a lesser contact or surface area of contact, which increases the stress in that, and it was shown that this can contribute to catastrophic polyethylene failure. So a lot of modern implants designs look at sacrificing the rollback to decrease the contact stresses. And they do this by having a more congruent fit between the polyethylene tibial insert and the femur. And this decreases those stresses by providing a bigger surface area of articulation. As a compensation, the designs have made the low point of convexity more posterior, which aids with flexion, as well as providing some posterior slope on the tibia to allow more flexion. So our cruciate retaining prostheses, they maintain the posterior cruciate ligament, obviously, and this decreases instability and flexion by preventing the femur from dislocating anteriorly on the tibia. And they can allow femoral rollback. We've discussed that femoral rollback does exist with PCL alone, and it allows better flexion. The disadvantages, as we've discussed, if there is rollback, it increases the contact stress. And again, just showing a straightforward cruciate retaining implant. The other unconstrained primary total knee we often look at is the PCL substituting, otherwise called a posterior stabilized or a PS knee. And this employs a tibial post, a polyethylene post, and a cam between the femoral condyles. And what happens is, as the knee progressively flexes, there's a point at which this femoral cam engages the tibial post. And at that point, the femur can't translate anteriorly. So that's a mechanical design of the prosthesis to prevent that anterior dislocation of the femur on the tibia, as opposed to the cruciate retaining prosthesis, which uses the PCL to achieve that. And because of this cam engaging the tibial post, this then can mechanically create rollback by pushing the femoral component more posteriorly on the tibia as it flexes more. The advantages of this technique are that having a mechanically controlled rollback by the prosthesis can allow a more congruent tibial insert to decrease the contact stresses and lead to less polyethylene wear. But the disadvantages of it are that it probably needs more careful balancing to achieve that. And if you have, especially in the sagittal plane, if you have a knee which is loose in flexion, you can have what's known as a cam jump, where the femoral component actually goes over the top of that tibial post, which can be very difficult to reduce without an anaesthetic. In patients that you're expecting a high flexion on, it's probably best to avoid these. Here's an example of a posterior stabilized knee. As you can see, the post in the polyethylene insert, and in this diagram here, you can see that as the knee flexes, this post engages here, which will then stop the femoral component translating forward. And then as it flexes more, the point of contact goes from more anteriorly to more posteriorly. So that's recreating that femoral rollback. Here's an example of a cam jump where the femoral component has gone over the top of that tibial post, and this generally needs a general anaesthetic to reduce in a flexed position with some distraction on the tibia, and then performing effectively an anterior draw to get that tibial post back in the femoral component. So generally we look at these posterior stabilised knees in patients that have had a previous patelectomy who don't have a strong enough extensor force to prevent the anterior femoral dislocation. Patients with inflammatory arthritis where ongoing inflammatory processes can cause a late PCL rupture. Sorry, that should be prior PCL trauma where they have rupture or attenuation of the PCL and potentially that not being a mechanical restraint there, and intraoperatively over-release of the PCL. Another design is looking at a knee with a rotating tibial platform, and this is having a tibial polyethylene insert that can actually rotate on its base plate. And the idea with this is to have better conformity between the femoral prosthesis and the tibial insert throughout the range of motion. Again, having better contact throughout and decreasing the contact stress. A particular thing that can happen with these is the bearing spin out, and that the actual tibial polyethylene can dislocate through rotation and become trapped there and need open release. And we want to avoid a loose flexion gap for that, because that's when the bearing can spin out. This is an example of that. So as you can see, the tibial polyethylene insert in this particular model has a post there, and that allows it to rotate on its base plate. They have radiographic markers in the actual polyethylene themselves, and this can help us identify which direction they're facing. In this particular example, this polyethylene insert has spun out and is effectively at almost 90 degrees to where it should be sitting. And here's an example of that intraoperatively, where the insert is now not sitting congruently under the femoral component like it should be down here where it's been reduced. Just quickly on complications, there are a number of complications of knee replacement, and our patients need to be aware of those when they're consented. And one thing that I wanted to briefly mention after we've talked about the design of the prostheses is failure, and in particular it's been shown that excessive loading in the prosthesis, which is what we're trying to avoid by both our prosthetic design and our techniques intraoperatively, excessive loading can cause early catastrophic failure, mainly because of the polyethylene either microscopically or macroscopically failing. And in this, we're not talking about long-term wear, which is something that's going to happen in all prostheses, but we're talking about the early catastrophic failure. And there's a few things that that relate to this: the thickness of the polyethylene, the geometry of our articulation, sagittal plane kinematics, as well as in preparing the polyethylene, the sterilising and machining techniques. Very quickly, if our polyethylene is a lot smaller, if its thickness is quite low, then it's going to have higher stresses at the point of contact. And it's shown that a minimum polyethylene thickness should be at least 8 millimeters. Now, we need to be careful with this. We need to understand what the implant companies are talking about when we're talking about a 10 millimeter polyethylene insert. Because a lot of times this actually means the base plate as well as the polyethylene, and not just the polyethylene alone. We've talked already about congruency of the articulation. If we have an articulation that is less congruent, there's going to be less, a smaller point of contact and increased forces and increased contact stress there. If we have a more congruent joint, then we're going to have that force more evenly spread out. And having a more even spread is going to have less point loading and less chance of early failure. And we've already talked about the sagittal plane kinematics and rollback, and how that can increase contact stresses. In the manufacture of our polyethylene, it's been shown that if our polyethylene is sterilised in an oxygen-rich environment, it can oxidize that, which can lead to weaker areas of the polyethylene. And also when the polyethylene is milled, this can create shear forces and stresses in areas where it's machined, and that can lead to some subsurface delamination of the polyethylene, and that can make it more susceptible to oxidation when it's sterilised. There's a number of other things when we think about total knee replacements in a number of areas of controversy, talking about resurfacing the patella, computer-assisted surgery, and also patient-specific jigs. And there's a whole world that can be talked about when we're talking about revision, but we won't go into any of these today. In summary, total knee replacement is a very technically demanding operation, and it's key that we know our patient and work them up and plan properly beforehand, and we know our prosthesis. And it all comes down to having good planning pre-operatively to try and achieve the best result for our patient.
Thanks, Jeff.